All right, so my name is Nadia. I've met some of you. I'm a fourth-year doctoral student at the Harvard School of Public Health and Infectious Disease Epidemiology. I went to Harvey Mudd College for my undergraduate degree, and I got it in math and biology. I know that's relevant to some of you. And I'm really excited to see all of you here, and I'm happy to answer questions at any time during the day. So it's good to see everyone. So today I'll be talking about sexy mathematical models, insight on patient zero, and sexual mixing in South Africa. And I'm going to build directly off of George's talk. So George sort of showed us how everything started, and this is where we are today. This is data from 2011 from UNAIDS, and hopefully you can semi-read this. But this is essentially to say that HIV is now a global epidemic. There's HIV in every part of the world today. And the numbers are really staggering to think that we started with 6, 7, 8 cases in the United States to, in sub-Saharan Africa, 23.5 million adults and children living with HIV in 2011. So we're really talking about something that's really widespread and obviously really serious. And you can see that the global numbers here are about 34 million. Now, what's interesting to me is that these numbers come from a model. So we can't actually count every person with HIV in the entire world or an entire region. So these are model-derived numbers, but we trust them like they're actual numbers representing how many people have HIV. So that's an important part to think about. Our numbers for prevalence, our numbers for incidence come from models. And models are really, really important. So I'm hoping to motivate that in the talk. So as George mentioned, we've come a long way from the first few years of HIV. We now have people talking about a potential therapeutic cure for HIV, which is pretty extraordinary. And there was reports in 2008 of the Berlin patient. Maybe some of you had heard about that, a man with leukemia who essentially got complete bone marrow transplant, and he had HIV, complete bone marrow transplant from someone who was CCR5 receptor negative, which means that the person did not have or had very limited CCR5 receptor cells, so HIV had a hard time getting into the cells. And this man is essentially free of virus a long time after the bone marrow transplant, which is pretty cool. Of course, the results of HPTN-052, which was a trial which we'll sort of talk about a little bit later on in the Journal Club, about sort of treatment as prevention, being able to reduce transmission by 96% by giving people treatment early. So we'll talk about that in Journal Club, I think, a little later on. And then the new news, which was at CROI this past year, about potentially a baby being cured of HIV. So these are exciting things that are happening in the HIV world, very far from where we came the first few years, and I would claim really motivational and maybe even sexy, and might encourage you to come into the HIV world because there's a lot to do. So we have a lot of tools in our toolbox now to think about prevention, and this is a list of some of them, and it's sort of stratified on who's getting the prevention intervention and how they're getting it. And so George talked a bit about sort of the letdowns in the vaccine world, unfortunately. But we do have a lot of other tools, including the basics, condoms, that still are effective. Behavioral issues, male circumcision, which was huge, and STD treatments. So we have a lot of things in our toolbox. The problem is we don't know how to use them or combine them in the most effective manner necessarily. And George referenced former Secretary of State Hillary Clinton, who made a statement to say that we can achieve an AIDS-free generation. We have the capability by using all of these prevention methods and combining them. The question is how to combine them. How do we combine them to be effective? And that's sort of what we're aiming to answer with models, I think. And maybe you'll agree with me that HIV is an extremely complex system. There's a lot of factors that come into HIV transmission, including disclosure, including other infections like tuberculosis. There's even infrastructure issues like food scarcity and poverty, and the list can go on and on and on. But the point is that HIV, so every time I show this slide, everyone laughs at the sugar daddies. But it's an issue. I spent a summer in Uganda, and the first thing I noticed when I flew in were these huge billboards addressing the sugar daddy issue, addressing the issue of older men providing goods or money or sort of recompensation for younger women to have sex with them. And it's an issue in a lot of parts of sub-Saharan Africa. So although it may be funny, it's there for a reason. But it's a complex disease. So how do you study complex systems? And that's really the question that I think Dean Burke sort of addressed a little bit earlier. There are two ways to study a complex system. You can experiment with the system itself, which is what I would call clinical trials, sort of doing things in the field, or you can create a model system, right? A model system that sort of runs on your computer. But there are two types of model systems. You could create a physical model, which is sort of what the drawing of the pipe was. You can think of an airplane model, like a physical airplane model. That's a model of a system, of an airplane. Or you can think of the mathematical sort, which is what I'll focus on, obviously. And there are two types of mathematical models. There are models that have analytical solutions, right? So you can solve them for a particular solution. And there are models that you can't solve, that you need to sort of exercise numerically through simulation. So we'll talk a little bit later in Journal Club. I think one of the papers you read was sort of the SIR deterministic model. That's a system that we sort of can solve analytically. But the model I'll talk about now is more of a simulation. We can't solve it. It's too complex, too in-depth. So that's sort of like the world of complex systems. And this is the world I live in for my dissertation. Very small world. So what is a model? And I know this may be a review for some of you, but I think it's important to talk about the basics a little bit. So there are many definitions for models, but the best one I think is it's a simplified quantitative description of reality. So we're trying in the best way possible to represent reality. But there's an important distinction between mathematical models, the way that I'm referring to them, and statistical models. So I know some of you study statistics, but in a statistical model, you're sort of looking at the association between an exposure and an outcome, and you're not really specifying how that association exists, why it exists, what's the pathway through which it exists. In a mathematical model, you're explicitly telling people that this exposure is related to this disease for this reason. So you're explicitly listing the pathway through which exposures affect disease. And that's really the difference here. So when you're talking about logistic models, those really don't tell you how things are associated. They just tell you that they are associated. In a mathematical model, you're telling people why they're associated, which is the distinction. But there are important components of mathematical models, and we'll touch on those in Journal Club as well. But one of the main things are the assumptions that are inherent in a model. And this is the first question you should ask when someone hands you a mathematical model, or if you're reading about a model in the literature. You need to ask, what are the assumptions that are being made? And an assumption is a thing that's accepted as true or as certain without proof. So you can assume something that doesn't necessarily need to be true, but you assume it to simplify the model. That's really the purpose of an assumption. So some common assumptions in the HIV world, for the SIR model that you guys read about, one of the big assumptions was that interactions between individuals are instantaneous. You can imagine a bunch of ping pong balls in a glass box, and they're just sort of bouncing around, and every time two ping pong balls touch, that's considered a partnership or an interaction, right? We know in real life that partnerships have duration, that that's not necessarily true, but we use that as a simplified version, something that we could use, that we can easily understand, and that's simple to code, right? Simple to represent. Another assumption we might make, which I'll skip to the third one, is that an individual's CD4 count cannot reverse and trend once put on ART. Does that make sense all the time? George didn't touch on this, but we have issues now with adherence. So although we have really good antiretroviral treatment that will sort of suppress the virus, if you don't take the treatment, it's not going to suppress the virus. And so making sure that people take their treatment and are adherent to their treatment is a huge issue. And in the real world, if you assume that everyone's adherent, you're probably wrong, right? There are a lot of people who aren't adherent to their medications. So that's another big assumption that we make. And then the next big piece of models are the parameters. And sort of the review that you guys were supposed to read before you came here really focused on the main parameters in an SIR model, right? You guys you looked at the contact rate, you looked at the probability of transmission per act, right? I think that was all in the paper. So parameters are characteristics or features of a measurable factor that can help in defining a system. So what are some examples? You guys read about this one, the risk of HIV transmission in an unprotected sexual encounter. And there was a really nice, actually, after I reread it, I realized that we could use it for our model. But there was a really nice summary of the different parameter choices that you have there. And then if you look at some of these other ones, they're a little bit harder to get from the literature, right? What is the rate of partnership change for an unmarried man? So how often does an unmarried man have a new partner? I don't know. And I don't know how to ask that question to get an accurate answer, right? It's really, really hard to get this data. And that's the other part of modeling, right? You really want to represent the system as accurately as possible. But it's really difficult to do that because it's really hard to get information on people's sexual activity and sexual behavior. Another one is the number of sexual contacts an individual has in a month. Again, if you ask someone, how many sexual partners have you had in the last month, are you going to believe what they tell you? Maybe, maybe not, right? They may have reasons to inflate the number. They may have reasons to deflate the number, right? And then the number of commercial sex workers in South Africa in 2001. A woman may not identify as a commercial sex worker for fear of a lot of different things, right? So these are all parameters that we need for our model, and we need to get them from the literature, but it's really difficult to. So this is something you have to keep in mind when you're reading about models. You know, people may represent their model as the most realistic model, but it really comes down to the assumptions, and it comes down to the parameters that they're using. So that's what I would encourage you to think about when you're reading about models. So this is the model that you guys read about in the background paper, the simple SIR model. And I put this up here just as a comparison to our model, which I'll talk about in a second. But just to walk you through it, for those who maybe are a bit unfamiliar with it, you have compartments of people. So now you're talking about groups of people, right, who are susceptible to the disease, who are infected with the disease, and who, for the sake of this conversation, have died from the disease, right? So they're completely removed from the population. And you have different interactions going on to cause people to move from the different compartments to the next compartments. Now, there's a big hint on the slide, but what are some of the major assumptions in this model? Just scream it out. No births, no deaths. So it's a constant population, right? That's obviously not realistic of a real population, but we do that to simplify in this case. And you could easily add births and deaths to this model. I'm not saying you can't. You can. What's another? That they're heterosexual, sure. Actually, in this case, it could be a general model. So it could be that you're talking about men who have sex with men in this case, too. So it's not particular. We haven't split the... So what we could do in that case is we could split the compartments into two and have one for women and one for men. But in this case, we haven't. It's just a general mixing population. Yeah. Right, so that the mixing is random. And you guys talked a little bit about that in your game this morning, which was kind of cool. But here we're assuming that there's no preferential mixing, that everyone is mixing randomly. So again, we have the ping pong balls bouncing around in the box, and we're not telling the ping pong balls, you can only play on this side of the box, right? Everyone's mixing. Those aren't, in my opinion, accurate assumptions for HIV in the real world. Now, we can get a lot of insight from a simple model like this. I'm not completely downplaying it. But is it realistic? Probably not, right? So I'm trying to talk up my model here, if you can't tell. So I'll describe what I'm working on for my dissertation. This is the CPAC dynamic model, and CPAC here stands for the cost effectiveness of preventing AIDS complications, and that is a separate model that's already established. It's a sort of biology-based model that looks at the biology within an individual, looks at the detail of CD4, viral load, opportunistic infections, things of that nature. So we've built a model on top of it to account for behavior. That's really what I'll be talking about. So, excuse me, it's an agent-based model, which means that we've moved away from the compartments of people, from the groups of people, and we're actually representing each and every individual in the model. We have data on every individual in the model, so it's a different sort of focus and a different feel. And it's stochastic. So you guys read about this in your paper. What's stochastic mean? So there's some random chance, right? There's some random variability in the model. So as opposed to deterministic, right, where there's no chance. Every time you run the model with the same parameters, you get the same result. In this case, every time you run the same parameters in the model, you get a different result. So there's some chance that's factored in. We're looking at male and female persons, and we're only looking at heterosexual behavior here. So we're making an assumption that in South Africa, where we're basing this model, there's only heterosexual transmission. So we're ignoring any men who have sex with men. We're ignoring injection drug use. We're ignoring mother-to-child transmission, which is a big one. But we're ignoring all those things, and we're assuming it's only heterosexual transmission. Now, there's data to say in South Africa that it is the dominant mode of transmission. So it's not a far-off assumption, because there's very little information on men who have sex with men and injection drug use in South Africa. But we are ignoring mother-child transmission, which is sort of a larger assumption here. And we're allowing people to enter partnerships, and there's 4 types of partnerships, which I'll describe to you in a second, concurrently, which means that you can have more than one partnership, so your partnerships overlap, right? You can have more than one partnership in a particular month, which is kind of big that we're able to look at this sexual network in this way. And it's a male-dominated selection algorithm, which means men in our model choose females based on certain characteristics, primarily age. So men have sort of a preference in our model for women who are 5 years younger than them, for example. So a man is likely to choose someone who's in 5 age buckets younger than them in our model. But it's male-dominated, which means that females, technically in our model, sort of don't have the ability to pick a male partner. It's always a male-initiated partnership. We also have something called behavioral risk. So this was talked a little bit about as well in the papers that you read. But we have reason to believe that there's a small proportion of the population that simply has more partnerships than the rest of the population. They can be considered high risk, right? So we allow for high risk and low risk individuals in our population. The difference is that high risk people have higher partnership acquisition rates. So they form partnerships more often than people who are low risk. So this is what a person looks like, in our model. We have a lot of information, including their age, their sexual activity status, which I'll talk about in a second, their gender, whether or not a woman is a commercial sex worker, whether or not they're high or low risk, whether or not the men are circumcised, and again, the partnership acquisition rates, the number of acts that everyone has per month. And then we have a lot of information on their health status, and this comes from CPAC, which I'll talk about in a little bit, from the other model that I was referring to. So we have information on their CD4 count, their viral load, whether or not they have any opportunistic infections, and at what age they were infected, if they were infected. So this is what the person looks like. So we carry a lot of information on every individual. And we run our simulations with 100,000 people. So we're carrying all this information for 100,000 people in our model. So it takes a little bit of time to run the model. And we're simulating every month. So every month we circle through 100,000 people to populate all these characteristics, which is pretty cool. So it takes a lot longer to run than the simple SIR model. So these are the partnership types. And this is really, I would argue, what makes our model different from a lot of the other models that are out there. We account for a lot of different partnership types, and we allow them to happen concurrently. So people can have a steady relationship, which is essentially, we try to think of it as sort of being in a married couple or having a long-term partner, maybe a live-in partner. So on average in our model, these partnerships last about 10 years. Okay? So they're sort of longer duration. But you can only have one at a time. So if you have one, you're considered non-single. But if you don't have one, you're considered single. So this is really the defining factor for your relationship status, if you're single or if you're non-single. And then we allow people to have regulars. So these are like long-term flings that you're sort of having on the side, right? Especially if you have a steady partnership. So these last, on average, about 9 months, right? So you can have this ongoing partnership outside of your, say, husband or wife that's about 9 months long. But you can have many regular partnerships. So you can have as many as you want. And some of these regular partnerships are really long. So some of them may last as long as 5 years, and some of them are really short. They may only last a few months. Then we have casual partnerships. So this is like a one-night stand, one-off. You have sex once, and you say goodbye. So this is more like the instantaneous partners that you see in the other models. And then you have commercial sex workers. So that only corresponds to partnerships where a woman in that partnership is a commercial sex worker. So we get the data from literature that suggests that the woman receives compensation for having sex. And again, that's a one-off, right? So you have one partnership, that's it, in that month, but you can come back to the same CSW in further months. So you can essentially have a long-term partnership with a CSW over a number of months, which we see from the literature as well. So these are all the partnerships we can have, and you can have all of them at the same time, right? So what kind of biological information can you get? And this comes from CPAC. So we have a lot more information about viral load, about opportunistic infections. That all comes from CPAC. So if you follow with me here on the bottom, an individual is born into the population in the CDM, and at age 17, they become sexually active. So we assume that the average age of sexual activity, start of sexual activity rather, or for everyone in our model, 17. So we've gotten that data from the literature. Once you become 17, you can start forming all of the partnerships that I've listed, and you form the partnerships based on the acquisition rates, right, that you're assigned. And the acquisition rates we get come from the literature. But there's a bit of heterogeneity. So men have different levels of acquisition rates. So a low-risk man will have a lower acquisition rate than a high-risk man, which causes there to be heterogeneity in the population, which is something else you read about in the Journal Club article. So let's say man 1 had a sexual partnerships with a commercial sex worker. He got infected. We're going to toss him to CPAC, to the disease model, to get information about his disease. So he'll go through primary infection, chronic infection, and late-stage infection, which I think you read about. Nods, heads, maybe? Okay. So as you know, in these different stages, there's different probabilities of transmitting to other people, right? So if you get infected with HIV, usually within the first 3 to 6 months, you have really high transmissibility. So it's very likely you'll transmit to your partners. In the chronic stage, it's relatively lower. And then in the late stage, once you start getting all of the symptoms, you start to infect people more often again. Not as high as the acute stage, but so just want to make sure we were all on the same page because that'll be relevant later. But you get some viral load data and some disease stage data. So that is a summary of our model, and I hope that made sense. It's hard for me to put up equations because it's algorithmic. It's an algorithm, right? There's not necessarily equations that I can show you. So this is the probability of transmission. So we account for circumcision, and we account for condom use in the probability of transmission. So if you're using a condom and if the male is circumcised, then there's a lower probability of transmission to that male, right? So we account for those two things. That's what this is. These are the only equations I'll show, actually, right there. So this is the flow chart of what happens in our model. And this is 1 month. So I'll try to walk through this relatively quickly and clearly. So we start at time step 0, which is month 0 in the model. And everyone ages 1 month. So once you hit 100 years old in our model, you're assumed to die. So no one can be older than 100 years old in our model. You could die for other reasons prior to 100 years, obviously, due to HIV or other issues. But the oldest you can be is 100. Then for each person, we decide if they've died. We dissolve the partnerships for those who have died, and we've moved the widowed partners back into the singles pool. So that's for people who have had the steady partnership, right? And then we update their health status. So we get information from CPAC about their CD4 count, about their viral load, whatever we need. Then we decide, okay, is this person newly reaching sexual debut? Are they starting to have sex? If so, then we set their status to negative, because they haven't had sex before, so we know that they're HIV negative. We set their CSW status for women, so we assign a proportion of new incoming women to be CSW. And then we set their risk level. Then we add births, we dissolve partnerships, and we update partnerships, and we exit. So that's what happens every single month for 100,000 people, right? And we run these runs for 1,200 months. So you can imagine that it takes a long time. I tried to set up runs last night to improve the graphs that I have, and they're still running. So you won't see them. So this is calibrated output from our model. In the green here, green stars, that's the UNAIDS data that I showed you earlier from 1990 to 2002. So this is prior to the advent of antiretroviral therapy. So we're talking about people who have not received therapy. And we see our model, which is all these colored lines, can represent the curve in a decent manner, right? That's just some face validity to what I'm talking about. All right, so now the exciting questions, and I have about 10 minutes, I think, to talk about them. Patient 0. Do we actually know who the first case in South Africa was? Will we ever know who the first case in South Africa? Probably not. And we think we know maybe who brought HIV to the US, as you guys just saw, but we still don't know that for sure, right? As he said, someone had to give it to me. So who is patient 0? We don't know, but in our model, we're able to explore these ideas in terms of the people that we have in our model. So we can explore whether or not a commercial sex worker could kick off the epidemic enough to give us what we see today, whether or not a high-risk man or a high-risk female could, or whether or not we can even kickstart our model with one person, right? So this was something we were even skeptical about. Can we do that with our model? And then this answers the question, what's the best way to seed the model? Are the results sensitive to the seeding? So for those of you who are math majors or who are familiar with math, a lot of you know that the initial conditions for any problem are extremely important. So this is essentially what we're doing here. We're trying to assess what the initial conditions are that we need to give an accurate representation. So we did a bunch of sensitivity analyses using the number of, so we're going to vary the number of initial cases, the type of the initial cases, meaning are they commercial sex workers, are they high-risk males, are they high-risk females? And then we'll also vary the HIV stage of the initial cases. So if we seed the epidemic with an acute person, will it take off in a different way than if we seed the epidemic with a chronic person, right? So I just talked about the different stages, so that's relevant. So let me get you first familiar with the plot. So here on the y-axis, we have the HIV prevalence. On the x-axis, we have months since the start of the simulation. So we're looking at prevalence over time in this case. And all these cryptic numbers are just for me to know which parameter set we're looking at. So it may not make sense, but I'll try to explain each slide here. So here I'm varying the number of initial cases we use to seed the epidemic. So in this case, the blue curve has 24 initial cases, evenly spread out between 17 and 24-year-olds who are commercial sex workers or high-risk males and females. So really, we're sitting with a lot of cases here, 24 cases at the beginning. And you can see that the epidemic takes off relatively quickly and maintains. Now, if you start reducing that number from 24 to 18 to 12 to 6, you see that when you see with 6, it takes a little bit longer for the epidemic to really take off, right? And it takes a lot longer to reach that plateau that we're seeing in the end. And in fact, you see that eventually, after month 1,000, you eventually overtake the other runs. So there's something about the sexual network. So we're seeding 6 people, and it takes off. There's something about the sexual network that's causing this takeoff to happen in month 1,000, right? So this just shows you that we can sort of determine how fast the epidemic takes off, partially by seeding with a different number of initial cases, which is or is not intuitive? Is intuitive? I see some people shaking their heads. I would think it is intuitive. Does anybody have a reason why it's not intuitive? Okay. Now that I said my opinion, maybe not. So I'm going to show you a second graph, and the second graph is going to be shifted, and I'll explain how in a second. So these are the same exact runs that I just showed you, but instead we've made time 0 the point at which each of these runs hits 0.08% prevalence. So the data we have from UNAIDS suggests that the prevalence of HIV in South Africa in 1990 was 0.08%. So what we're doing is we're taking each of those runs and we're shifting the runs such that 0.08% prevalence now becomes time 0 and now represents 1990, if that makes sense. So now this plot is showing you 1990 to 2002. So you see the stars again that show you the UNAIDS curve that I showed you earlier, and you see our simulation runs, right? So we're only seeing a really small portion of this curve here. You'll also see that the run that I picked to show you doesn't really represent the UNAIDS curve really well. And hence the reason I was trying to run something different, but it took too long. So forgive me. We do have runs that look more like the stars, but you get the picture even from these runs. What's interesting here is that if you only look from 1990 to 2002, you see a really nice trend in the sense that the more initial cases you have, the higher the epidemic. Yeah?
You know what you changed to make it more like that curve? What variables?
There's a lot of variables that we can change. Yeah, we can talk a little bit more about that later on, but there's a lot of variables. Yeah. All right, so here's another run. Here we're looking at the HIV stage of the initial cases. So I've initialized the blue curve, which is, hopefully you can see it, is the highest curve here with acute cases. I've initialized the green curve with chronic and the turquoise curve with late. And then I've also varied sort of the number that we initialize with. So the base case here is 24. Maybe you can't see it, and I should have probably focused in, but the point is that initializing with acute cases causes the fastest epidemic growth, which you might expect. But initializing with 12 cases produces slower epidemic growth, which supports the notion that I just said. The fewer initial cases you seed, the slower it takes for it to take off. But you can see with this particular parameter set, they're not all that different. They don't have that great spread. And again, this is just, when shifted to 1990, they all look the same, and there's not really a trend. Now here's another run where I was just trying to compare chronic to late stage, simply for the sake of there's a smaller difference between chronic and late stage than there is between chronic and acute. So I would think they're more similar. But you do see that because late stage has a higher transmissibility, you see this higher rise in the epidemic than you do here. So late stage transmissibility can actually cause an epidemic in and of its own, even though it's not as high as the acute. So these are actually one run for this sake. As I mentioned, it takes a long time to create them, so we will be averaging over time. No, so what you're viewing here is Nadia's attempt to get these graphs done faster and reducing the number of people. So here we're only looking at 10,000, which is why you see the squigglies. So there's less people. It doesn't average out as nicely as when you have the 100,000 people. So forgive me. I was anxious. And then here, we have a lot of different parameter sets. And what we're doing is we're changing the stage from acute to chronic. So the originals are acutes, and the non-originals are chronic. And what you see is that we see a slight delay in the epidemic for each of these runs when we change the initial cases to chronic, which is what we would expect because there's a lower transmissibility. They still take off, but it's just a slight delay. Now, what if we talk about the type of individual that we seed with? So I'm realizing I'm running out of time. But if you follow my cursor here, all of these runs are initialized in low-risk people. And so what you observe is that it takes a lot longer to actually kick off the epidemic in low-risk people, which is interesting because it's intuitive. I mean, you would expect that high-risk people like this patient 0 in the United States would infect a ton of people all at once. But the degree to which the delay happens is interesting, and it's something we're trying to understand better. But when you shift them all to 1990, so what I'm doing is I'm taking this run and I'm making that time point 0, and I'm making this time point 0. So when you shift them, they look relatively similar. All right, and I think this might be one of my last slides. There's sensitivity to the risk type. So if we look at CSWs versus high-risk females versus high-risk men, in this case, it was surprising that it took the CSW epidemic to kick off, but it's dependent upon the parameters here. So the CSW acquisition rate was really low, so men weren't actually having a lot of CSW partnerships, which is why we see this delay. But what you can see is that you can cause different epidemics depending on the risk structure. So by seeding in different people, you sort of get different levels of the epidemic, and also you can see that it takes a really long time for this epidemic to take off, which is interesting in and of itself. To think about how far back, how long before 1984, 1983, 1980, was there actually HIV present in the population, right? We only saw it when it hit a certain point, when we had a certain number of cases. But it could be as far back as, I don't know, 2, 3, 4 years. We don't know. All right, so this is patient 0. So now we are seeding the epidemic with one person. And we actually can see a takeoff, which was somewhat surprising to me. But it's possible to seed with just one person and get an epidemic in a pretty reasonable amount of time, which is pretty cool. And in this case, we're only looking at high-risk females and males, and the younger the person, the more likely it'll take off, which is pretty cool. Same thing here. So we have a number of analyses that we've planned in the future, and my dissertation will come out of this model. So I'm hoping to look at test and treat, which is the question we're going to be talking about later on, using this model, which is much more sophisticated than the Greenwich model that you guys will discuss in the afternoon. There's a lot of people to thank that I work with, but most importantly, I wanted to put my email address up here. Please feel free to write it down and email me if you have questions. But just put something in the subject line, like Chicago or like something.